Hello everyone, so welcome to another video in the series Thinking Like a Medical Registrar. Today we're talking about weight loss. So my name is Vishal Kumar. I am the founder of KeenMedic.com and this YouTube channel. So this series is all about how you can think like a medical registrar, and this will help you immensely towards your PACES exam. So stay with me until the end of the video. We're gonna be learning loads in this video. So let's get started. We are going to be talking about, first of all, the unmissable diagnoses that you need to cover in every single weight loss station, and then how to prioritize, and then how to investigate, and then how to manage appropriately. Finally, a quick summary for you to remember at the end of the video. First and foremost, the unmissable diagnoses. So in every single presentation, there are certain things that you cannot afford to miss, especially as a medical registrar, okay? And in weight loss, there are a few things, okay? I'm gonna simplify it for you. There are the big three, okay? And these are malignancy, diabetes, and hyperthyroidism. So quite easy, really. Just three things for you to remember that you cannot miss, okay? Well, if you miss, then you are going to be in big trouble because you're most likely going to fail. And in real life, it can cause a lot of issues for your patient and ultimately you as a clinician. So these three things that you need to always look out for when you are with a patient who's come in with weight loss. All right. So, okay, you're thinking about all of these three things. What about the rest? Surely weight loss is caused by many other things, right? Yes, of course they are. So let's talk about the other things then. Some things that you should think about are infectious causes, okay? And these are not things that you will see often, but they do come in. So keep a lookout for them. These are TB, HIV, as the most common diagnoses amongst many other things, okay? So TB is very common, especially in ethnic minorities who have lived outside of the United Kingdom and have come to the UK, or if they have been born in the UK but have spent substantial amounts of time away from the UK and have been in contact with patients with TB. Essentially. So similarly, that also applies for HIV, but of course there are other risk factors for HIV, like shared needle use in IV drug users, or having tattoos not in the UK, where the needles may not be clean, or having unprotected sexual intercourse, okay? And again, this applies more to outside the UK and having multiple sexual partners, things like that, and also blood transfusions. So these are things that you should look out for, infectious causes, okay? Other causes like rheumatological causes do happen, again, a bit less frequently, but things you need to look out for are lupus, systemic lupus erythematosus rather, SLE, okay, and of course systemic sclerosis. These are the two things that you need to look out for in the rheumatological sections. Other things like neuropsych causes can also cause weight loss. So this is a situation where there is no organic cause, okay? So you have ruled out all of this stuff, you've ruled out the big three, and now you're thinking about, okay, so has the patient got low mood, or have they got signs of poor cognitive function? So things like dementia and depression, okay, where dementia may just be because they have slowly over time forgotten how to eat, or their drive to eat has gone down, okay, or they may have a poor swallow because of their dementia. And similarly in depression, they just have a very poor appetite, so that may be because of that. So dementia, of course, is often a irreversible situation. Well, it is an irreversible situation and tends to progress. So that is something that you need to keep in mind. Depression can be treated in a lot of cases. Some cases it cannot be, and it may be refractory. This is all, of course, after you have ruled out medical causes, and if they are that bad, if they are causing weight loss, then the psychiatric team should always be involved, okay? You shouldn't be dealing with this kind of thing on your own. And lastly, motor neuron disease. This is, of course, not just a psychiatric cause, it's a neurological cause. Okay, that's why I put it there. So motor neuron disease could cause weight loss if the patient has got poor swallow and they're not eating because of that, and that can of course also cause other things like aspiration pneumonia if they've got poor swallow. So motor neuron disease can cause weight loss, and in these kind of patients, for their feeding purposes, you would consider PEG tube, feeding tube through the anterior gastric wall. Okay, so these are all things that you should keep in mind when assessing a patient with weight loss. Bear in mind though, you need to think about the big three first and foremost. Okay, you cannot miss the big three. All right, and any long-term conditions basically that can cause organ failure, like renal, cardiac, or hepatic. Of course, all these can cause weight gain in the form of fluid retention, but they can also cause weight loss and cachexia over time if they're not in acute decompensation. Okay, so this is how you should prioritize. Okay, so we talked about the big three earlier. So you need to first look at the patient. So weight loss can come in any context, whether this is history or your station 5. Okay, it may even be in communication, but the first thing that you will have at your disposal is the patient in front of you. So just look at the patient. It's as simple as that. Look at the patient top to toe and look who they are. Okay, look at their overall demographics. Start off with the age. So are they in the younger age bracket? Are they 30 or below? Are they in the middle age, like 40s to 50s, or are they elderly, 75 and above? That kind of thing. Are they male or female? Are they cachectic? Okay, so these things are the very basic foundations that you need to be looking out for, followed by things like ethnicity and origin. So this will point you towards diagnoses like TB, for example, tuberculosis. Okay, if they originated from India or Pakistan, for example, or from parts of Africa, then you may be suspicious of whether this patient may have TB, especially if they've had infective symptoms or if they've been in contact with TB contacts. Okay, all right, and again, look at them. So look at their hands. The hands will always be visible. Look at signs for calcinosis, sclerodactyly, and also any rashes that might suggest systemic sclerosis or lupus. Tattoos and needle marks are not always visible, but they may be visible, so do keep an eye out for them. If not, you could always ask them, which is what leads on to the next bit of this presentation. So you need to then quiz them, okay? Ask them the questions, the right relevant questions that will point you towards your diagnoses. So travel, smoking, other constitutional symptoms. These are important for the big three, but also for things like TB and HIV. Osmotic symptoms for diabetes, so stuff like polyuria, polydipsia, weight loss. Okay, so weight loss is what we're talking about. So polyuria and polydipsia being the key features, and features of hypothyroidism. So this would be stuff like having palpitations, diarrhea, skin changes, hair loss, tremors. Okay, so things like that. Features of systemic lupus, erythematosus, or systemic sclerosis. So this would be stuff like oral ulcers, photosensitivity, and systemic sclerosis, things like telangiectasia under the lips, calcinosis, tightening of the skin over the hands and mouth. Travel to TB countries, again, parts of Asia and Africa being the typical countries that you would expect, and or having had exposure to close contacts, which may well be within the UK. All right. So what can happen is that the patient's families can have TB and they may not be aware of it, and they may well be living with them, and although they themselves will not have traveled to countries with TB necessarily, high prevalence of TB, what can happen is their family may have done so, and they will have contracted the illness from the family member, which is why close contacts is important. And risk factors for HIV, as I covered earlier on, stuff like unprotected sexual intercourse, dirty needles when they're in IV drug users, blood transfusions outside of the UK, stuff like that. So in terms of investigations, you do need to prioritize. Okay, you have to make sure you don't miss the big three. You have to make sure that is at the top of your priority, guys. So always consider the standard blood tests. So these are stuff like a full blood count and urea and electrolytes. So what they will do is point you towards the right direction, and they will tell you whether or not the patient is anemic, and if they have got, say, microcytic anemia. And if they do, you should do always things like ferritin levels and iron levels, because then if they've got iron deficiency microcytic anemia, that in an elderly patient, for example, that is highly suspicious of a malignant cause, and you should definitely investigate this further. So the way you might do this is by doing, first of all, a chest x-ray, okay, and looking at any obvious shadows, masses that might be on the x-ray, and always considering an endoscopy. This can be a lower and upper GI endoscopy, okay, to look for evidence of malignancy or bleeding points. And if the patient is particularly frail, you might consider a CT of the entire body, which is the chest, abdomen, and pelvis usually, okay, in the first instance. Or if you think that you have found a primary lesion or just a metastatic lesion, then you may also do a staging CT of the chest, abdomen, and pelvis to look for other areas of metastases. All right. And thyroid function for one of the big three that I mentioned earlier, hyperthyroidism, and of course HbA1c, which will look at diabetes control. And then you would proceed to the rest, okay? So this would be HIV, your early morning sample for this sputum to look for TB, and also autoantibodies for your connective tissue diseases. And finally, CT or MRI of the head with or without neurology input, depending on what you're thinking. Like, for example, depression and dementia. So the psychiatric team would always want a scan of some kind before you ask for their input to rule out any organic causes if they've got weight loss due to a psych cause, if you think, okay? The other thing that you should also be thinking about, if you haven't found a cause, is gastroenterology input, because often, endoscopies may not necessarily find a source of malignancy, but gastro team can be very helpful in providing advice regarding weight loss specifically. So how are you going to manage? So weight loss is a huge area, okay? So as we covered, there are many different differential diagnoses, and even what we've covered today, it's not comprehensive, okay? There are many things that you need to think about. So this will depend entirely on the underlying cause. So you need to think about how you can provide support, and this can come in the form of dietitians who can then calculate the daily requirements in terms of calories and the best form of supplemental nutrition that the patient might need. As for managing further, this would again depend, as I said, entirely on the cause, and you may need oncology input if you found a malignant cause, or endocrine if you think that the patient has got hypothyroidism or diabetes, infectious diseases for things like TB and HIV, rheumatology if they've got SLE or systemic sclerosis. So I hope that makes sense, guys. So let's talk about the summary quickly. We've covered a lot today. So first and foremost, don't ever forget the big three, okay? Don't do that. So the big three are malignancy, diabetes, and hyperthyroidism, and then think of the rest, okay? You do need to think of the rest, because at the end of the day, this is PACES, and really anything can come up, but you need to think about these three first, okay? And then prioritize everything. Always seek help from the relevant specialties, including dietitians. So regardless of what the diagnosis might be, remember that you are not alone, okay? Remember that you can seek the advice and input from the multidisciplinary team. So this may be oncology, endocrine, respiratory, gastroenterology, neurology, psychiatry, many other things, okay? And always talk to the patient and their families and keep them informed. So I hope that makes sense, guys. If you want to learn more, make sure you check out my book on strategies for PACES, which is available in the Kindle and the book format, and also my course. The links will be down below under the video. I will see you in the next video.